So I'm Lori Reigenstreif. I'm a primary care physician and MD, family doctor with a number of different titles from Canada.
You're not quite loud enough.
What's that?
You're not loud enough. Can you?
Oh, I'm not loud enough. Okay. I'm a physician from Canada. I'm primary care. I actually have a focused practice mostly in addiction medicine, so I look after a lot of people with alcohol and opioid use disorders. And what I wanted to talk about was really what doctors need to know to provide excellent care and what might be getting in the way of that happening, particularly in North America. And I had a really engaging conversation with Carrie Mendoza. She's a physician who's an emergency physician from Chicago last night and changed all of us slides. So because I think she brought up a couple of really important things that I hadn't thought about and I think are really important to put into people's minds as you fly on your planes to go home, because I think it's going to be really important. So doctors need real information. There's primary care settings, and then there's emergency care settings where what Carrie would call unplanned care is being provided. And in order to do that, they need real information. And one of the other things we want to talk about is changes to electronic medical records, particularly I think in North America, and the impact that those changes to those EMRs is going to have and is already having on health care. I'm sorry, I'm just going to look at where we are. Good, just making sure we're doing it. Yeah, okay. So really briefly, how are we doing?
Good.
Really briefly, as this is relevant to anybody who goes to a doctor and people who take histories as physicians as well. What you tell a doctor is basically about your symptoms. You're going to tell them what's important to you, what you think they need to know, but they're also going to need to know a lot of other things. They're going to ask you a lot of other questions. They might even seem like they're being nosy, and they're not. They need a lot of information to be able to make decisions about what's going on, for them to understand what's going on, and for them to be able to develop a treatment plan, which hopefully will be a collaborative event that happens with you and you involved, and if it involves a child, hopefully includes their parent. Most importantly, among those things, usually at the very top of the chart is the biological sex, and that's how we went through medical training, was 30-year-old female with an F or an M, and that immediately conveyed medical information from one colleague to another, and a lot of that is being erased. So the other things you might, if you have the luxury of extra time, share with your doctor are things like, what are the priorities? What are your priorities? What are most important to you? What are issues that are in their scope of care? So are these things that they're going to be able to help you with, or are they going to be able to, or are they going to need to refer you to a specialist perhaps for surgery or for further diagnostic testing? And which issues will need referral? And what's happening, and I'm seeing this more and more with transition and detransition presentations, or people who've been through medicalization and surgery and post-surgical complications, because I'm starting to see more and more individuals in Canada who are, and a little bit in the States, who are being referred over to me, who have medical needs that are really reaching into the realm of uncertainty for a lot of physicians. And this is an area that physicians get very uncomfortable with and can often be a little bit obstreperous. So developing a therapeutic relationship becomes incredibly important. I just wanted to, I threw in this slide because yesterday we ran a little workshop, which became a real brainstorming session with some of the detransitioners who've been attending the conference. And really in addressing the needs and gaps in healthcare, we're going to require the input from people with experience. Now, incorporating lived experience is actually turning the triangle upside down for some areas of medicine, where they're deciding that people with lived experience should actually be deciding policy. That's not what we're talking about. We're talking about the essentials of asking people who are possibly the only people who've ever experienced this combination of symptoms and signs before. So getting together with them and hearing from them what would be helpful for them to help them navigate the healthcare system was really, really helpful to me. And a couple of the things we came up with were something called a detrans doula, which would be a system navigator with some regional relevance for people in different countries. medical information navigation, and we may be able to do something virtually that we've been talking about to help people access, in particular detransitioning adults, and to access reliable, credible medical information, which we know is evidence-based and solid, and not based on an online survey with cash prizes. And also the development of care networks for people, helping them link to primary care providers who hopefully will help them navigate the very complex system that's going to rise up around them. So I want to let Carrie speak, and we're both going to participate a little bit, but I'd like her to speak to this second set of slides that we've made.
Yes, thank you, Lori. I didn't mean to have you change your whole presentation, but I'm from FAIR, the Foundation Against Intolerance and Racism, and there's a medical section called FAIR in Medicine, so I run that. But I do still do clinical shifts in emergency medicine, mostly in the south side of Chicago.
All right, that's too advanced, but you're going to advance your slide here. So
Click this. Okay, is that?
Yep.
Okay. Okay, I'm going to do a quick case study. Now, just a little background. The ER is really like the wild, wild west in a way, because we see, I call it the good, the bad, and the ugly. The things that work well in our healthcare system, like stroke alerts, cardiac arrests, but we also see where the healthcare system is breaking down. So here's a case study. So a 25-year-old trans woman comes to the ER complaining of abdominal pain. So some generalized pain, you get the history, some heavy drinking the night before. They have a benign abdominal exam, labs are unremarkable. They're given some Pepsid and Maalox, the pain improves, and the doctor gives them a diagnosis of gastritis and sent home. Kind of common stuff, right? Okay. So she returns the couple days later with ongoing pain. A second doctor examines and says, well, I need to do a GU exam, basically a testicular exam. And they note a right testicular mass, and they order an ultrasound because they're suspicious they need to know what the mass is. And it turns out the radiologist says it's suspicious for cancer, so they arrange for a biopsy, and the person ends up having testicular cancer. So that's an example of a doctor who didn't even think of doing a proper exam on the first case. So this is really about electronic health records. I don't know how it is in Europe, but in the States, basically there's a software overlay that basically enters all your medical information. And this is another example of a case where this particular this is in the New England Journal, actually, it's still up, where a trans-identifying female, a trans man comes in saying they have abdominal pain, and basically goes through the system, and they don't, identify that it's actually a female, and the person basically has a miscarriage, a stillbirth. So,
It's quite harrowing when
Yeah.
you read it. Even as a physician, as a human, like reading this,
Yeah.
this case, you're able to kind of project your humanity into the medical aspects of it.
yeah, I mean, basically the person came in, and because they weren't identified as a proper biological, entity, that they didn't recognize that this person was pregnant and basically had a miscarriage and went through a lot of pain. And this is in the New England Journal still, it's up. So my point with the electronic health record is that it's a software overlay where people enter data. This is from 2013, 10 years ago. WPATH recognized they needed to get into the electronic health record because that is the reality in the hospital. So everything we're talking about is super important, but I'm talking about the world of how it really works. When you go in the hospital, it's dangerous now because they are basically registering people based on the sex that they say they are. Okay, that's very dangerous. I gave you one example that was kind of a little bit of a mishmash of a couple things from a case I had, and then the second one, like I said, is in the New England Journal, is still up. But you have to understand that this movement we were talking about in a political fashion is ahead of the game in knowing how to make their political prescriptions a reality. Okay, so this is an example of when you click on the sex on a patient's medical record in the States, a hospital can decide to now have this extra overlay. This is a form in there that the registration person or maybe in the gender clinic is going to fill out. But I'm already seeing problems on the back end. Like I had an 85-year-old male, I work in southern Wisconsin too, an 85-year-old male came in, not in this world, but as the nurse was entering his health history, it had a whole section about female health, like he had hysterectomy, all this. This was not this person's issue. So already on the back end, there's mistakes happening, and my nurse couldn't advance in the record. They had to call IT. This is an emergency department. Luckily, this patient wasn't having an actual emergency, but the record was locked. She couldn't advance. So these kind of messing with the records is really, really, it affects everybody. So again, there's this registration based on what somebody feels that has implications for all of us. There's also a generation I see of a staff who are either scared or ignorant about asking to do a full exam because they may say, oh, well, that's politically incorrect to ask to do a testicular exam or to do a breast exam. That's dangerous because you can miss things. These are humans. These are their bodies. You can't fall into this. And then I've already talked with several detransitioners that they can't get the records changed back. So I'm calling it the Hotel California for us older folks who know the Eagles. Like, you can check out anytime, but you can never leave. So that's a little bit about medical records. So when you go to the hospital, one thing we can all do is you have to ask and say, I want to make sure this is properly reflected. And for folks who want to change it back, you have to be persistent. So, thank you. Yes, please do.
Two things. One, I was engaged by a coroner to weigh in on a case where a trans woman who was 42 years old and had been on estrogen quite a long time had been having consistent chest pain over periods of weeks and had been going to the emergency department. And they've been saying, well, she's a female, she's on estrogen, and she's only 42. Her risk of heart problems is low. And this happened repeatedly until she actually died in her room of a heart attack. And the coroner was asking me about this, and I said, well, first of all, she was obviously hesitant to go in the first place. So she waited until because she didn't want to she wanted to deal with the staff and so on. There was a trust issue. But she also, they labeled her the way we label 42-year-old female, 42F, which to us would be moderate risk, maybe. Do they smoke? No. What medications are they on? But it's not the same as real information. The other thing I wanted to share was just something that came up I'm on a couple of Facebook parent groups, and this morning a mother had posted a little story about her daughter getting her driver's permit and was giving her mother a hard time because the mother was, I guess because she's under 18, wouldn't check off the non-binary box in the driver's permit application. And the mother said, nope, if you get in an accident, I want them to know what you are. So I thought that was just very timely. That was this morning. I think we actually have like 5 minutes, or do we have 5 minutes for questions? Or?
Yeah, a few minutes.
Okay.
A quick question, yeah.
That's great. Thank you. Perfect. Yeah, that's great. No, I think that.
Morning. Yeah, so I'm not a medical professional, but yeah, it occurred to me that, hey, if you don't have a biologically accurate picture of who you are, if you go in for medical treatment, you're not going to get the optimal or even safe treatment for yourself, right? And I tried to make this case, and people get angry, transphobia, blah, blah, blah. One thing I noticed when I was getting a checkup recently was that they had a form, the standard form, blah blah blah, age, this and that. The thing that they put was sex assigned at birth. Basically, that was their whole attempt to sidestep the whole self-identification, to actually have something that's biologically accurate. But the thing that does concern me now is, people who are supposedly raising babies, identifying their children as non-binary at birth. So, when they get older, there's that whole minefield that they have to cross. Just want your views on that.
I think, and it depends on where you are. I've also seen sex assigned at birth, male, female, prefer not to say. Now, I don't know if I don't take people's information when they're coming in. We get the information down the road. Someone else is bringing this all in. But what's a little scary is that the layers that start to form in a hospital setting each time you visit, you may change those things too. They can change some of these things. We have in our system, it says it may say biological sex or legal, then it'll say legal sex, preferred gender, or legal gender, preferred gender, and there's a fourth one. It gets to the point where all the time is being spent by the healthcare system messing with this stuff and not delivering excellent care. So.
Yeah, and again, the point is that it's being messed with on multiple, like the game of telephone, and it's getting messed with, and it has real implications. For me in the emergency department, it's regional. So in the Black community in the south side of Chicago, where I mostly work, this whole thing is not an issue, okay? Southern Wisconsin, where I work, I've seen, there's a little bit, but one hospital is in sort of metro Chicago, in the gay community, before they changed the records, it really wasn't an issue. Someone would register, and then in the margin it would say, identifies as a woman, likes to be called Sue, and no one had a problem. We all respected that. There was no issue, but it was correct in the medical record. Then that got changed with all of this. So you just, again, I think the message is that for all of us, you have to be very, very aware this is going on now, because it literally will affects everybody, okay? And the fact that it's hard to get it changed back is very, very, concerning. But, for me as a physician, like I don't play this game. I'm like, I won't indulge in this. I call the IT and say, hey, is this actually tracked? Like if I try and order a pregnancy test, is what's going to happen? The IT people don't even really know, but I'm out there and I won't back down on calling this out. So
there's a question
yes,
over here.
sorry.
I don't know if we'll get to 3 questions,
Yeah,
but
I'm coming over to Colin then. So we'll do here and then Colin, is that okay? Hi, I'm Greta. I've been working in child and adolescent mental health for 15 years, and I worked in a crisis team. So we went into A&E regularly, needed the information quickly, and we would get referrals, and we would be expected to change the biological sex on the medical records for the Rio mental health system, and I know that affects cervical screening and prostate screening stuff being sent. I just wondered, what can we do? I'm not in it now, but I will be going back in, and what can we do to challenge that, because it's not acceptable.
at the level that, I don't say level you're at, but the angle you're coming in from to address a problem like that, I think is possibly to share with a management level or administrative level person, the New England Journal of Medicine article, or the story, if anybody's familiar with Buck Angel's story about almost dying from sepsis in Mexico, and no one knew, I think he was unconscious or very ill and delirious, that he had a high fever and had actually a uterine infection. And these kinds of stories, I think, are probably the best way to convince them, or I don't know, if I'm not great at the management level of medicine, but that's the kind of thing I think we have to do as our, nattering little advocacy.
And I'll just say I'm a survivor of dealing with the opioid crisis. I worked before that started, during it, and seeing how it's persisted. And I know that just we would complain to the hospital administration, and they sort of really didn't care. But in the States, patient experience is important. So I do know that people, again, need to take it upon themselves to write the president of the hospital and say, hey, I have a problem with this. Again, I do my part, but yeah, that you need to, or like talking about the forms, when I go for my healthcare stuff, I cross all that stuff out and I let them know this is, not appropriate. So.
And physicians, if you know physicians, you could get them to start making noise, because they tend to have a little bit more edge, a little bit more power. I hate to say that, but it's true.
Okay, so I'm Colin Wright with the Manhattan Institute. I think the problem's going to get, there's activists attempting to make it even a lot worse by not just muddling some medical records after the fact, but also sort of moving sex demarcations below the line of demarcation on even birth certificates to start out with. There's an article that's in the New England Journal of Medicine in 2020. It's called Failed Assignments, Rethinking Sex Designations on Birth Certificates. And the first sentence is, sex designations on birth certificates offer no clinical utility. They can be harmful to intersex and transgender people. And they argue for, this is New England Journal of Medicine. I think the journal discovered, the clinical course of AIDS and discovered platelets. And now they're saying that sex is not of any clinical utility.
Well, it's like the Babylon Bee, so just ignore that. It's ridiculous.
The credibility of the New England Journal of Medicine.
No, but
today,
but how the world really works, where it's important for everybody, not just trans and detrans, every human here, is the fact that when you register at the hospital, or God forbid, you're in the ER, so they don't, they're not looking up your birth certificate. It's like the DMV. They don't know whatever someone put on their birth certificate, but they register them. They come in and they say, I'm a male or I'm a female. Obviously, you're unconscious. We just look at your driver's license, but obviously in the ER, we just, take your clothes off and see what's going on. That's just the reality of it. We're very practical that way. So I'm just saying that this is where the rubber meets the road when you're at the doctor's office. No one's looking up what they put on it. But yes, it's part of the alternate Babylon Bee universe in the States to think that. So.
Thank you both.